Right now, like as you're listening to this very sentence, your blood is hovering at a pH of about 7.4.
Yeah, right around there. Give or take a tiny bit.
Right. And if that number drops by just zero point 0.2, you could literally end up in a coma.
Exactly. Or, if it goes much higher, your muscles could just start seizing up entirely.
It's terrifying. So today we're doing a deep dive into this invisible, really high-stakes tightrope walk that's happening inside your veins right now.
It's such a phenomenal topic, honestly.
It really is. And to do this, we pulled a huge stack of sources for you. We've got core medical pathophysiology textbooks, critical care journals, and some pretty wild historical ICU case studies, too.
Yeah, because the margins for survival here are just shockingly slim. I mean, the body's defense of that incredibly narrow window, which is strictly between 7.35 and 7.45, it is one of the most aggressive systems in human biology.
Right. Uncompromising. But before we get into how the body actually pulls this off, we kind of have to clear up this massive misconception I saw repeated all over our sources.
Well, the terminology issue.
Yes. You hear the words acidosis and alkalosis thrown around a lot, right? Usually on, like, health blogs trying to sell you alkaline water or whatever.
Right, yeah. The wellness industry loves those words.
But in clinical medicine, there's this very strict distinction. Acidosis and alkalosis are the invisible processes that are pushing your body off balance.
Exactly. They are verbs, essentially, actions.
Right. The actual resulting number on a blood test, whether the blood itself is acidic or basic, that's called acidemia or alkalemia.
And that distinction, I know it might sound like a medical pedantry to some people, but it is actually the key to understanding, well, everything we were talking about today.
How so?
Because acidosis and alkalosis are just underlying processes, right? So you can actually have two completely different diseases pulling your blood pH in opposite directions at the exact same time.
Oh, wow.
Yeah, and the bizarre result is that your final blood pH might look perfectly, normal at 7.4.
But it's completely masking the fact that your body is in the middle of this lethal chemical tug of war.
Precisely. Two fires burning at once, but the thermometer looks fine.
Okay, so it's like having a thermostat in your house that's set to a ridiculously strict 74 degrees.
Okay, I like this.
But instead of one standard HVAC unit, you've got multiple rogue heating and cooling systems. So say a space heater is blasting in the living room.
Which would be your acidosis.
Right. And then an industrial air conditioner is just blasting in the kitchen, which is your alkalosis.
Yeah.
You look at the central thermostat on the wall, and it reads a perfect 74. So you think everything is totally fine, but the house is actually this chaotic mess of opposing energies.
That is a brilliant way to visualize it. And, to understand how diseases hijack those heating and cooling systems, we really first need to look at the body's built-in damage control.
The defense mechanisms.
Right. How does it stop that thermostat from shifting in the first place? Our sources outline 3 overlapping lines of defense. And the crucial thing for you to focus on here is their timescale.
Because they operate on totally different biological clocks, right?
Completely different.
I noticed that in the reading. The first line of defense is immediate. Like, we are talking fractions of a second. These are your chemical buffers.
Yes. And the heavy lifter here is the bicarbonate and carbonic acid pair. Though, you also have hemoglobin in your red blood cells and various proteins in your blood plasma helping out.
So how do they work exactly?
You can think of these buffers as like microscopic chemical sponges just floating in your bloodstream.
Okay.
The second an acid enters the blood, and remember, an acid is just a free hydrogen ion, these sponges instantly bind to it. They pull it out of circulation so it can't drastically swing the pH.
But sponges can only hold so much water before they're just completely saturated.
Exactly. They fill up fast.
And once those buffers are full, the acid starts accumulating. And that is when the second line of defense kicks in, which is respiratory compensation.
Right, which takes minutes to hours to really ramp up.
And the sources mentioned the brainstem is heavily involved here. It's like the control room.
It is the ultimate command center for this. There are these specialized sensors in your brainstem, and they're constantly basically tasting your cerebrospinal fluid for carbon dioxide.
Tasting it? That's so weird to think about.
It is, but CO2 in the body acts as a volatile acid. So if your blood is getting too acidic from some sort of metabolic problem, the brainstem detects that rising acidity.
And then what? It just makes you breathe faster.
Exactly. It immediately cranks up your breathing rate. You literally start exhaling the acid out of your body as a gas.
Wow.
Yeah, it's a remarkably fast and powerful way to just dump acid.
But I imagine breathing heavy isn't a permanent solution. I mean, you'd get exhausted. So if the problem is chronic, you need to call in the heavy machinery.
The third line of defense.
Right, renal compensation. The kidneys.
Yeah.
But this is the slowest of the bunch, taking anywhere from like 1 to 5 days. What are the kidneys actually doing that takes them so long?
Well, the kidneys are managing the root of the problem. They're playing in the long game. They can physically alter how much bicarbonate base they reabsorb from your urine back into your blood.
Okay.
And even more impressively, through this process called ammoniogenesis, the kidneys can essentially manufacture brand new bicarbonate from scratch.
Wait, they just build it out of nowhere.
Basically,
Good.
by breaking down amino acids and excreting the acidic byproduct out in your urine. But because this involves, actually changing genetic expression and building new cellular transporters inside the kidney tissue.
It takes days to ramp up. That makes sense. Okay, let me try to synthesize this for everyone listening.
Go for it.
Think of your body as a ship that just sprang a leak. The chemical buffers are like tossing water out with a bucket.
Immediate, but you're going to get tired very quickly.
Right. Then respiratory compensation is like firing up the ship's mechanical bilge pumps. It's fast, it's loud, and it moves a ton of water.
Yeah.
But renal compensation, the kidneys, that's like sending a crew down into the water to slowly rebuild the ship's actual hull. It takes days to fix the root structure.
I love that analogy. It perfectly captures that escalating response. But there is a cardinal rule here that the textbooks emphasize really heavily.
Oh,
Compensate never, ever fully normalizes your pH.
wait, really? It never goes back to perfect? I thought that was the whole point.
Never. The body's compensatory response only blunts the impact. It won't push the pH completely back to 7.40, and it absolutely never overshoots into the opposite direction.
Why not?
Well, if you think about it logically, if the body perfectly normalized the pH, those sensors in the brainstem would think the problem was completely solved.
Oh, I see. They would turn off the bilge pumps.
Exactly. The body actually needs a slight, lingering, abnormal signal to keep the compensatory systems running.
Okay, so if I see a blood test where the pH is totally normal, perfect 7.4, but the CO2 and bicarbonate levels are just all over the place, that is a massive red flag.
A gigantic red flag. It does not mean the body successfully fixed itself. It means there are two primary diseases happening at once, that mixed disorder we talked about earlier.
The two fires burning. That makes total sense.
Yeah.
So let's look at what happens when these defenses actually get overwhelmed. The sources dive into some really fascinating pathologies, starting with DKA, diabetic ketoacidosis.
Right. This is a classic, really severe metabolic acidosis. In DKA, a lack of insulin means the body just can't use sugar for energy, so it panics.
And it starts breaking down fat instead, right?
Yes, at an extreme rate. And a byproduct of that rapid fat breakdown is a massive overproduction of keto acids.
And when a patient is in DKA, their blood pH just plummets. Those chemical buffer buckets are overflowing instantly.
Oh, immediately.
So the body triggers the bilge pumps, the respiratory system. I saw the sources mention a really specific term here, Kussmaul breathing. What does that actually look like at a patient?
Oh, well, it was first described by this physician named Adolphe Kussmaul back in the 1870s, and it is unforgettable once you see it in person. Yeah. It is a very specific, rapid, incredibly deep, and labored breathing pattern. The patient looks like they are just starving for air, gasping deeply.
But they aren't actually lacking oxygen, right?
Not at all. Their brainstem is just screaming at their lungs to blow off as much CO2 as possible to lower that acid load in the blood. They are literally hyperventilating to save their own life.
Man. So Kussmaul breathing is the body responding to an internal acid fire. But what happens if the environment forces you to hyperventilate when you don't actually have an acid problem? Like, say, when mountaineers go to extreme altitude.
Right. Well, the thin air up there forces them to hyperventilate just to get enough oxygen to survive.
Right.
But by breathing so fast and deep, they are unintentionally blowing off massive amounts of CO2.
Which is their acid.
Exactly. They are exhaling their natural acid, which plunges their blood into a respiratory alkalosis.
But they don't just stay in that alkalotic state, right?
Yeah.
I mean, this is where the slow shipbuilders, the kidneys, finally come in.
Yes, and this is actually the physiological reason behind that famous mountaineering rule, climb high, sleep low.
Oh, really? I've heard that phrase.
Yeah. Because over a period of a few days, the kidneys sense that the blood is way too basic. So to compensate, they start actively dumping bicarbonate out of the body through the urine.
They just throw away the base.
They intentionally waste base to bring the pH back down toward normal. It is just a fundamental part of how humans acclimatize to high altitude.
That is so cool. So the body adapts over days. Let's take that concept and apply it to a chronic illness, though. What about someone with severe COPD, like chronic obstructive pulmonary disease, emphysema, that sort of thing?
Okay, so these patients have damaged lungs, right? So they chronically underbreathe. They trap CO2 in their chest day after day, year after year.
And because CO2 is an acid, trapping it means they basically live in a constant state of respiratory acidosis.
Yes, but since it is a chronic long-term problem, their kidneys have had months or even years to slowly build up this massive mountain of bicarbonate in the blood to neutralize that trapped CO2.
Which brings up a really dangerous scenario from the critical care journals we read.
The ventilator trap.
Yes. If that COPD patient's body has spent years adapting to this high CO2, what happens if they get like a bad pneumonia, end up in the ICU, and a doctor puts them on a ventilator and just suddenly fixes their breathing in 10 minutes?
Well, you have just created a life-threatening crisis.
Wow.
Because by using the ventilator to rapidly blow off all that trapped CO2, you are removing the acid instantly. But remember the timescale we talked about. The kidneys are slow.
Right.
They spent years hoarding all this bicarbonate base, and they just cannot dump it in 10 minutes.
So the acid is suddenly gone, completely blown off, but the giant mountain of base is just still sitting there in the blood.
Exactly. The patient is instantly plunged into a severe, highly dangerous state called post-hypercapnic metabolic alkalosis.
Post-hypercapnic, meaning after high CO2.
Right. And it's an iatrogenic complication, meaning it was accidentally caused by the medical treatment itself.
Because the doctor looked at the respiratory monitor and just tried to fix a number.
Completely forgetting about the slow metabolic machinery running in the background, yeah.
That perfectly highlights a really dark, but honestly crucial part of medical history we need to discuss. The danger of trying to just fix the number.
It's a huge...
Right. For decades, well-intentioned doctors tried to treat the lab value on the screen rather than understanding the underlying process.
And the most famous and probably disastrous example of this is the historical use of intravenous sodium bicarbonate during cardiac arrests or, severe acidotic states.
Yeah, because, intuitively, the math seems so simple. If a patient's blood is incredibly acidic, you just grab a syringe full of base, bicarbonate, and inject it into their veins. Acid plus base equals neutral. Problem solved, right?
On a chalkboard, sure. But human physiology isn't just a simple beaker of chemicals.
Right.
When you inject that liquid bicarbonate into highly acidic blood, they react together to form carbon dioxide and water.
Okay, but we just established that we can breathe out CO2, so what's the issue?
Well, the issue comes down to a physiological barrier. Carbon dioxide is a highly diffusible gas. It crosses cell membranes and the blood-brain barrier almost instantly.
Okay.
Bicarbonate, on the other hand, is a charged ion. It crosses those same protective barriers incredibly slowly.
Oh, no. So that massive burst of CO2 gas rushes into the brain before the base can even follow it.
You've got it. The CO2 floods into the brain cells and the cerebrospinal fluid, and once inside the brain, it reacts with water to form acid again.
Oh, my God.
So the doctor looks at the patient's blood work, sees the arterial pH number has improved, and thinks they saved the day. But inside the patient's brain and inside their organs, they have paradoxically created a lethal, suffocating acidosis.
Wow. It's literally like trying to cool down a sweltering, burning house by just taping an ice pack directly to the thermostat on the wall.
Exactly.
The digital readout says a perfect 72 degrees, so the doctor walks away happy. Meanwhile, the house is just burning to the ground.
That is exactly the illusion that was happening. And it's why today, major resuscitation guidelines have sharply, severely restricted the use of IV bicarbonate.
They just don't use it anymore.
It is reserved for very specific, narrow situations, usually involving specific toxicities or kidney failure, but not as a general fix.
So if fixing the number is that treacherous, how do modern clinicians actually measure and understand this stuff? The textbooks mention a few different philosophical camps.
Yeah, there are a few different frameworks out there. The oldest is the Boston approach, which was built in the early 1900s around the Henderson-Hasselbalch equation.
Which basically looks at bicarbonate and CO2 as the two primary drivers of pH, right?
Exactly. Then in the 1960s, you had the Copenhagen approach, which introduced this concept of base excess to mathematically separate the respiratory and metabolic components.
And both of those make intuitive sense based on what we've talked about. But the sources spent a lot of time on something called the Stewart approach, developed by Peter Stewart in 1978. And this is where things get genuinely mind-bending for me.
Oh, Stewart completely flipped the script. He argued that pH isn't driven by acid or bicarbonate at all.
Which sounds crazy.
Right. He said pH is just a dependent variable, like a bystander. He claimed it is actually dictated by 3 independent forces, the most important being something called the strong ion difference.
Okay, I need you to slow down and explain this mechanism to me, because when I read this in the sources, I was completely lost. The strong ion difference is just the balance of fully dissociated salts in the blood, like sodium and chloride, right?
Right.
How does changing salt levels suddenly create acid out of thin air?
I know it sounds like magic, but it's pure physical chemistry. Think about water. Water is H2O. It naturally wants to maintain a neutral electrical charge.
Okay, with you so far.
When you dump an excess of a negatively charged ion, like chloride, into the blood, you severely disrupt the body's electrical balance. And to fix that Sutter electrical crisis, the water molecules in your plasma physically split apart, releasing their hydrogen ions to balance the charge.
And a free hydrogen ion IS, an acid.
Yes. By altering the salts, you force the water itself to generate acid. Bicarbonate just passively changes its concentration in response.
Okay, so this Stewart guy proved that salt can manipulate water into becoming acid. But is this just some, academic thought experiment, or does it actually matter for someone lying in a hospital bed today?
Oh, it literally changed how we hydrate patients globally.
Really?
Yeah. For a century, the standard IV fluid hung in every single hospital was 0.9% saline, often called normal saline. But normal saline actually contains significantly more chloride than human blood does.
So pumping liters of normal saline into a trauma patient is artificially spiking their chloride.
And throwing off that strong ion difference. Under Stewart's model, giving all that extra chloride forces the blood to become acidic. It causes what we call a hyperchloremic acidosis.
Just from the IV fluid.
Yes. For decades, doctors debated if this even mattered. Then, a massive ICU study called the SMART trial finally proved it.
What did they find?
They showed that switching away from normal saline to more balanced, lower chloride fluids actually reduced major complications, including kidney failure and death.
Wow.
Stewart's complicated math literally reshaped modern critical care.
That is incredible. But let's pull back from the ICU for a second, because you don't have to be on a ventilator or getting liters of IV fluids to experience this chemical tug of war.
Oh, definitely not.
These acid-based mechanics are happening in your everyday life. Let's take a panic attack.
An incredibly common example. When someone is experiencing a panic attack, intense anxiety drives them to hyperventilate. They blow off huge amounts of CO2, quickly pushing their body into a respiratory alkalosis.
And if you've ever had a panic attack or been with someone having one, a classic symptom is they will say their lips are tingling or their fingers are going numb. Why does that happen?
It is a direct physical result of the alkalosis.
Right.
Yeah. First, the sudden drop in CO2 causes the blood vessels in the brain to constrict, making you dizzy. But more interestingly, when the blood becomes basic, it actually changes the electrical charge on the proteins floating in your plasma.
Okay.
Those proteins suddenly act like magnets for calcium, binding it up tightly.
So your level of free floating calcium just drops.
Dramatically. And this transient drop in ionized calcium causes your peripheral nerves to become highly unstable and hyperexcitable. They start firing off randomly, which creates that classic tingling pins and needles sensation around your mouth and in your hands.
It's amazing that a symptom we often write off as being, all in someone's head during a panic attack is actually a measurable drop in free calcium caused by a shifting pH.
It's pure physiology.
What about exercise?
Well, when you sprint up a flight of stairs or push yourself during a heavy workout, your muscles burn through oxygen faster than your lungs can deliver it.
Right.
To keep moving, the muscles switch to anaerobic metabolism, which produces lactic acid. That burning in your legs, that is a real-time lactic acidosis. Oh, wow.
Your chemical buffers instantly soak up what they can, and your breathing becomes heavy and labored well before you feel fully exhausted. That heavy breathing is your respiratory compensation kicking in to blow off CO2 and balance the rising acid.
The sources also talk about diet, specifically the ketogenic diet, which is, incredibly popular right now.
Right. When you go strictly keto, you deprive your body of carbohydrates, forcing it to burn fat for fuel. This generates ketone bodies, putting you in a state of mild ketosis.
Which sounds familiar.
Because it is. The fascinating part is that this is the exact same metabolic pathway that causes diabetic ketoacidosis.
Oh, wow.
It's just functioning at a much lower, tightly controlled level in a healthy person, whereas in a diabetic with zero insulin, the process runs completely out of control.
So we've talked about how obvious some of these symptoms can be, right? The hyperventilating, the tingling lips, the burning muscles. But what about when a disease is completely hidden, like the sneaky normal?
The hidden fires, exactly. The sources highlight a diagnostic tool called the anion gap. How does that help clinicians find those hidden fires?
Developed in the late 1970s, the anion gap is basically a mathematical trick. Clinicians take the main positive ion they measure in the blood, which is sodium, and subtract the main negative ions, chloride and bicarbonate.
Because in reality, all the positive and negative charges in the body have to equal zero, right? They cancel out. But the blood test doesn't measure every single tiny particle.
Exactly. There is always a small gap in the math, usually around 8 to 12, which represents the negative proteins and small organic acids we just don't routinely measure.
Okay.
But if a doctor does the math and that gap is suddenly like 25 or 30, it tells them something terrifying.
Which is?
It means there's a massive amount of unmeasured hidden acid flooding the bloodstream.
Even if the pH looks totally normal because the body is compensating.
Yes. An elevated anion gap screams that there is a severe underlying problem, like hidden lactic acid from a massive infection, ketones from uncontrolled diabetes, or some kind of ingested toxin.
And medical students are taught that mnemonic, right? Mud piles.
Yes, mud piles, to remember all the obscure toxins and diseases that cause this specific gap.
Speaking of hidden fires and toxins, our sources point to one specific over-the-counter drug that is considered the ultimate pedagogical villain when it comes to causing a mixed acid-base disorder.
Ah, aspirin, salicylate poisoning.
Yes, what does it do?
It is a fascinating and deeply dangerous poison in large doses. A massive overdose of aspirin does two distinct, highly destructive things at the exact same time.
Okay.
First, the salicylate crosses into the brain, heads straight for the medullary respiratory center, and artificially stimulates it. It chemically forces the person to hyperventilate.
So that creates a primary respiratory alkalosis. They're
Yeah.
blowing off CO2 uncontrollably.
Yes, but at the same exact time, the salicylate poisons the microscopic mitochondria inside your cells. It basically destroys your cell's power plants.
Oh, no.
Instead of making clean energy, the cellular machinery panics, breaks down, and starts churning out massive amounts of toxic, acidic waste.
Which creates a massive metabolic acidosis.
Exactly. So you have an aggressive base-producing process and an aggressive acid-producing process happening simultaneously.
The two fires.
If an ER doctor just looks at the basic pH, it might read exactly 7.40. It looks absolutely perfect. But the patient's body is being ripped apart by two simultaneous lethal physiological fires.
That is terrifying.
If the doctor doesn't look deeper, check the CO2, the bicarbonate, and calculate that anion gap, they will literally send a dying patient home.
Wow. Okay, so zooming out, what are the big takeaways for you listening right now? First, remember that acidosis and alkalosis are the invisible processes at work, not just the final number on a lab report. You can have multiple pathological processes fighting each other at once.
Absolutely.
Second, timing is everything. Fast breathing fixes things in minutes, but the kidneys take days to rebuild the hull of the ship.
Right.
And third, your body's compensation never fully normalizes a problem. If the pH is completely perfect, but the other numbers are wildly off, you are likely looking at a sneaky mixed disorder, not a cured patient.
And, you know, if we take a step back and connect all of this to the future of medicine, for decades, the medical consensus was that an abnormal pH was the ultimate enemy. If the number was wrong, you did whatever it took to fix the number.
The ice pack on the thermostat.
Exactly. But in the year 2000, a landmark study called the ARDS-NET trial completely shattered this paradigm.
Oh, what happened there?
They were studying patients with acute respiratory distress syndrome, so people with severely fragile, failing lungs. The traditional medical instinct was to put them on a ventilator and crank up the pressure, forcing air into their lungs to drive their CO2 down, just to make their blood pH a perfect 7.4.
But cranking high-pressure air into already fragile, dying lungs causes massive physical trauma, right?
It does. It was destroying the very tissue they were trying to save. So the researchers tested a radical, highly controversial idea.
Which was?
What if we just let them be acidotic?
Wait, really?
Yeah. What if we use incredibly gentle ventilator settings? protect the lung tissue, and deliberately allow their CO2 to stay high and their blood to remain acidic. They coined the term permissive hypercapnia.
Permissive hypercapnia, deliberately allowing the abnormal state to exist.
And the results were undeniable. Survival rates improved significantly. This trial completely revolutionized how we manage ventilators worldwide, and it actually became a cornerstone of how intensive care units kept COVID-19 patients alive during the hardest parts of the pandemic.
That's incredible.
It proved a humbling lesson for modern medicine. Sometimes clinical perfection isn't achieving a textbook number. Sometimes allowing the body to sit in an abnormal acidic state is exactly what it needs to survive the trauma.
I love that. So the next time you take a deep breath or feel your heart rate spike on a run or feel the tingling of panic, just think about that invisible, microscopic tightrope walk happening inside your blood right now. It is a chaotic, uncompromising, and absolutely brilliant balancing act. Thanks for taking this deep dive with us.